Okay, good morning, good afternoon, good evening, wherever you are. It's great to see you all joining this webinar. I'm Joachim Stromberg. I'm the Foundation President of the International Society for Systems and Complexity Sciences for Health. And this topic is one that's quite close to my heart. One of the things that's very clear to me is that modern medicine, with its focus on RCT and guidelines, is moving further and further away from engaging with complexities that underpin health as much as disease. We now have a pretty good appreciation how our health is influenced by our external environment, perturbating our internal function, and how our given biology regulates our internal functions. This is a representation of putting it in a visual environment. In the end, we as people are sitting at the narrow bit of the hourglass, influenced by our external environment and our internal function. And it doesn't matter what is on top and what is on bottom. It always will interact with each other. Our webinar has two aims. Firstly, to review some of the key aspects of physiology, the physiological complexity, and secondly, to highlight how these understandings translate into clinical practice. Our speakers come from different walks of life. Andrew is a thoracic surgeon and intensivist who has extensively studied the applicability of real-time heart rate monitoring as a predictive tool for intensivists in the critical care environment. He will start us off in a moment. Nick is the psychologist and stress researcher with a particular interest in building resilience. And Wolfgang, being a physician, musicologist and educator, studied the effects of music on restoring and maintaining well-being. It should be a really exciting perspective coming from so many different clinical applications. I'm looking forward greatly to each of the contributions and lively discussion afterwards. Andrew, if I hand it over to you to start us off.
Thank you so much. It's a pleasure to be here, and thank you for putting this wonderful seminar together. So I shall just share my screen. Can you see my screen?
Yes.
Yep.
So I thought I just have a few slides to share with you, and your discussion about interacting with the environment is very much a part of my discussion, and I look forward to our discussion. So thanks again. So really, in summary of what I try to do is to improve care using the monitor data that we routinely monitor at the bedside and typically discard after monitoring the present moment. But we use a combination of technologies to try to improve care. And fundamentally, the technology is variability analysis. So what's at the root of heart rate variability and respiratory rate variability analysis. And I combine that with AI or machine learning to create predictive models, and then which we combined with standardized processes and checklists to improve care through improving decision-making of physicians. That's kind of the overall approach. The first approach that we used was to address the timing of extubation in the intensive care unit. So extubation is a critical transition as you are recovering from critical illness and coming off a mechanical ventilator is fraught with danger, in that if you get it wrong and patients fail extubation, it has an enormous impact and harm. And what we found was that respiratory rate variability was the best predictor of extubation outcomes, and here allowing you to distinguish between a high risk and a low risk patient, which is very helpful to that decision. And we've embedded that predictive model in a tool called Extubation Advisor. Secondly, we looked at whether heart rate variability could predict future deterioration in patients with infection. And because patients who deteriorate with infection on the wards of hospitals, again, cause themselves enormous harm and cost hospitals significant quantities of money. And we found that heart rate variability, combined with some lab values, was the best predictor of future deterioration. So 1 to 72 hours later, again, very useful to help to identify whether a patient should be admitted into a step-down unit or an ICU, or is safe to go to a ward if they've been diagnosed with infection. And thirdly, we've also looked at heart rate and blood pressure variability to predict rapidity of death in patients who are candidates for donation after circulatory death. So DCD donation is the largest, or it's increasing our capacity to lead to organ availability for transplantation. But a patient needs to pass away quickly after withdrawal of life-sustaining measures in order to make that possible. And again, variability is very helpful to predict that likelihood. And so, and all of this is sort of underlies that, like, the underlying physiology is that health is characterized by a high degree of variability and a high degree of complexity of variability. And that reflects sort of robust function at rest and our capacity to augment it. So akin to having a low basal heart rate and a high maximal heart rate, that's what variability can give you a measure of. And illness is characterized by reduced variability, both degree and complexity. And I'll just mention briefly about what I mean by the word complexity. So complexity is one of the key hallmarks of heart rate and respiratory rate variability is multi-scale self-similarity, and which has often been called fractal variability. And the concept is that when you magnify the pattern, you get the same pattern, and you magnify it. It's like a coastline. You magnify it, and you get the same. You uncover more detail. And that the fractals are everywhere in nature, and so this led me to think that multi-scale self-similarity must be physical, not biological. And if you look at all of these types of fractal structures in nature, they are all characterized by energy dissipation, and they spontaneously form in nature. Of course, this is a painting, but that's what is similar amongst all these. And the question is why? I believe that they're associated with the concept of entropy production. So energy dissipation is really equivalent to entropy production. And why is this important? Is it helps understand why these structures form spontaneously, and then that's, I think, due to recent advances in physics, which really highlighted how nature seeks to pursue the greatest ascent of entropy. So the second law of thermodynamics states that entropy is always produced in a system. It's delta S is greater than 0. But the fourth law of thermodynamics states that nature will choose the path of greatest ascent of entropy, and complex systems that are far from thermodynamic equilibrium seek states of maximal entropy production. And I think this helps explain why we get the creation of ordered structures in nature and in biology, And this is fundamentally how we interact with our environment. We are continuously dissipating an energy gradient by burning oxygen to carbon dioxide, and that's the way we stay alive. And so I just thought that is an interesting kind of relationship that governs sort of the interaction with environment of all complex nonlinear systems. And it leads to all sorts of potential ways of envisioning therapeutic interventions, and by thinking about health as characterized by both elevated resting and maximal entropy production, which I think reflects the combination of this physical law as well as evolution. And so that is all I would like to share. And these are the wonderful people I get to work with all the time. So thank you so much for sharing, or allowing me to share those ideas. And I will stop sharing. And I look forward to discussion. Did that all come through?
Thanks a lot, Andrew. We hand over to Nick.
Of course, happy to. Let me see if I can share my screen. You should be able to see that, do you?
Yep.
Okay, perfect. So, very inspiring and thought-provoking presentation by Andrew. Thank you so much. I feel like that what I can present and will be able to contribute is a little different in terms of that. My work is more on the very basic science area and less complex. I think the complexity will have to come by you, the other people, integrating my little data points into a bigger picture. So the presentation, and I tend to have too many slides. So Joachim, if you want to interrupt me at some point, do so, but I just try to talk a little bit about the things that I like to look at, which are basically the pathways between the central nervous system and the periphery, how stress can lead to disease. What I like to look at and visualize it as is that we do have stress or related states that are related or found in the central nervous system, and I'm interested in how that translates to changes in health. And if you look at that, there's different ways to figure out how this is mediated. Of course, there's behavior. We know that health behaviors are important, but we like to look on the other side here, which is the biological side. And we like to look at stress systems and how stress systems are changed when people are in states of stress or depression, or just in general states of, for example, loneliness, which has been shown to have strong effects on health. When we do that, of course, stress systems are the ones that we like to look at first. And I've just tried to visualize them here a little bit. The HPA axis that secretes cortisol, here GC, and the sympathetic nervous system with epinephrine and norepinephrine as mediators. What I like to say, and what I think is important, is that we don't have a direct pathway between any of these messenger changes and health, but we have to put something in between. We have to find a pathophysiological mechanism. And we like to focus on inflammation because we know that inflammation is controlled by, activated or deactivated by the stress system. And we know that inflammation plays a significant role in the development of many of the diseases that are important for us in the industrialized world. So that's basically the focus of my work. Just for introduction, I like to depict what we see as an acute stress response. So if you stress someone for 15 minutes in the lab, that's what we do a lot with our participants. You get a quick sympathetic nervous system response. You get a quick but a little delayed HPA axis response. And you get a much slower but still pronounced increase of inflammatory mediators. So that's basically what we like to look at when we think of an acute response of the organism to a threat from the outside. Now the question is this increase in inflammation that happens for a short time, is that really something that makes you ill, or do we have to look at more chronic conditions? So that's what we like to do here. And that's also reflected in, I think, the title, Joachim, that you put to my talk. So basically that when we look at chronic stress conditions, we have to look at the basic activity of these different systems. And I've shown cortisol here. We know that cortisol has a circadian rhythm with a sharp increase in the morning and a decrease throughout the day. And in a healthy organism that repeats every day. If you put someone under chronic stress, or if life puts someone under chronic stress and you get people in the lab, you will find that many of them show a hypocortisolism, so show lower activity of stress systems or of this stress system. And together with that, we typically see an increase in sympathetic nervous system activity and also an increase in peripheral inflammation. And we believe that this increase in inflammation is probably, I don't want to say caused, but it can be the result of the combination of increased sympathetic activity and decreased cortisol availability. So we think that the increase of inflammation is kind of the factor that makes chronic stress, if it happens for a long time period, something that affects long-term health. So what we don't know so much is how this develops over time. We do know that a healthy organism shows this pattern. We do know that over time, an organism under chronic stress shows this pattern, but we don't really know what happens in between. So we don't know if there's a phase of high cortisol in between. We don't know what the sympathetic nervous system does in between, or what the inflammatory system does in between. So we try to visualize it like this. So if you look at the entire lifespan, our question is, if you have stress events or potential stress events throughout your entire lifespan, does the increase or the repeated experience of stress lead to an increase of damage mechanism that I try to visualize here? This could be inflammation. Basically, it fits to the development of low-grade inflammation over time, but it could also be seen as something else, like accumulation of DNA damage or mitochondrial health or mechanisms like that. So what we like to do is we like to assess acute stress response patterns at a specific time point in someone's life to see where they stand at a specific point, and then ask the question, what does it mean for long-term development? And as you can imagine, we have not gotten very far in looking at long-term development of health, because that would require 10-year longitudinal studies, and that's difficult to do. So what we like to focus on is chronic stress studies, most of them short-term longitudinal or cross-sectional, and acute stress studies where we look at patterns and try to see if these patterns are related with current health. If we look at acute patterns, we like to stress people in the lab by a 15-minute laboratory stress task, typically seeing this response. This could be cortisol, as I've shown before. And Bruce McEwen has come up with a couple of patterns that would be called maladaptive. For example, when people are exposed for the first time, you could have a missing response or an inadequate recovery. Or if you're stressed again, normative response would look like this, the habituation, but you could also see non-habituation or sensitization, not on the slide apparently, but it could also be an increase on the second exposure. When we do that in real people in our experiments, what we see is a sympathetic nervous response that shows some kind of habituation. This is alpha amylase, but we also see this in physiological parameters. With cortisol, we see habituation from the first to the second response. And with inflammation, interestingly, we do not see so much habituation. The inflammatory response to stress seems to be something that habituates less easily or takes more repeated exposures to habituate. This is not completely studied. So maybe this could be the final or pre-final slide. The way we like to look at this is that we like to look at this inflammatory mechanism shown here. So this is supposed to be an immune cell with a nucleus and some receptors on the outside and intracellular proteins here, I-kappa B and NF-kappa B. And what typically happens if an immune stimulus is detected, like a bacteria or other pathogen, you do see this pathway of inflammatory activation that basically works by freeing up the NF-kappa B transcription factor to go into the nucleus. And the interesting part for me is not this immunological mechanism. I'm not an immunologist, but I hope to understand a tiny bit of that. But the interesting part is that you can basically put the brain up here and describe that the HPA axis with cortisol has an effect, which is an anti-inflammatory effect, a well-known effect to suppress inflammation. But what's interesting, you can also add the sympathetic nervous system here on the other side, and you can basically take away the pathogen and just look at the brain and how it regulates inflammation, showing that the sympathetic nervous system can activate inflammation without a pathogen present. And the HPA can basically inhibit inflammation also without any extra stimuli, meaning that even if you're not an immunologist, it's interesting to look at inflammation because the brain can basically switch inflammatory responses on through this pathway and off through this pathway. And that makes it interesting to us because that's how we think that a lot of the damage can be mediated by having an overactive sympathetic response relative to an HPA axis response or basal activity. You can basically control the inflammatory levels in your blood. And I see, Joachim, you're unmuting yourself, so maybe it's time to move forward. I can leave that as a thought-provoking slide for a discussion to follow after the next talk.
Yeah, that would be nice.
Good. Let's do that.
And
okay,
well done, Nick, because you created a perfect segue to Wolfgang's way of thinking about physiological complexity and how to modulate it. Wolfgang, over to you.
Thank you very much indeed, and hi to everybody, wherever you are. Thank you for explaining those stress mechanisms to which I will also refer. So firstly, I'm mainly working in clinical areas with music, with dance, with arts therapies. So that's my background. That's my domain. Quite often, when we say we work with music therapy, people who do not really know, who are not very familiar with this area, they say, oh, okay, perhaps patients may like music, or it perhaps has an influence on the mood, but the thing is deeper. So first of all, I would like to focus a little bit on music and neuroplasticity. You know, neuroplasticity is quite an umbrella term, and it refers to the ability of the brain to create and to modify neural networks. So neuroplasticity is absolutely important for all learning processes. It is somehow the neurological or neural basic of education, of personal growth. So everything that has to do with the psyche, with thinking, with experience, and so on, is based on neuroplasticity. We know on the one hand that neuroplasticity, of course, is determined by the genetic system. So our genes, the DNA, has a very distinct influence on neuroplasticity. In addition to that, we know that together with the DNA, epigenetic mechanisms, so how the gene functions are expressed, how they really influence the physiological system, is via epigenetic mechanisms influenced by experience, by the arts, by lifestyles, and so on. So the first aspect is, when dealing with neuroplasticity, we jump into a multidisciplinary domain: genetics, epigenetics, neurosciences, cultural studies, life studies, and so on. It only can be understood in a complex, in a dynamic way. We know today, the recent studies, that stress, that anxiety has a very negative impact on neuroplasticity. So neuroplasticity is not only important for personal growth and education, neuroplasticity plays a crucial role in neurological rehabilitation, in neurorehabilitation, for example, after stroke, for example, after brain surgery. So patients need neuroplasticity to reorganize their brain structures. If they are full of stress, if they have anxieties, those psychopathological conditions have a negative impact on neuroplasticity, and in that way they hinder, they obstruct somehow the rehabilitation. On the other hand, and now there's the focus on music. We know through a lot of studies, for example, at the Department of Neuroimaging at Harvard University, that music has a tremendously positive impact on neuroplasticity. That means through music experience, we can really boost brain plasticity. So combining music therapy and neurorehabilitation, psychiatry, and so on helps patients to reorganize brain systems. We know the fact, but the underlying mechanisms are still somehow unclear. We know today, and that's very clear, we cannot only think in a one-dimensional way. We cannot say, okay, there's the sound, and the sound increases neuroplasticity. We have to consider many, many systems. I'd like to explain shortly how complex this transfer from music to neuroplasticity might be. We're listening to music. We enjoy music, we like that, but what are we doing? So in the environment, we just have the sound wave. The sound wave is not music at all. The sound wave is just a physical phenomenon. What is going on now? In the inner ear and the corti organ, we transform the physical information into a neural information, into an electrochemical information. And now that's the first very crucial point concerning complexity. We know the physiological mechanisms, but from the perspective of information theory, we do not know what this qualitative transition from the physical information, from the sound wave, to the neural information, to the electrochemical information, makes, how this changes the information. It goes on via the brainstem, for example, the cochlea and nuclei in the brainstem, they begin to differentiate that information. They differentiate the pitch, the intensity, and the duration of a tone. And with those three elements, we can construct, and I like to use the word construct because it's somehow a physiological mode of constructivism. With those elements, we can construct each auditory phenomenon. It goes upwards, and we have a lot of centers in the brainstem which work on this raw material of the sound. And in the auditory cortex, we transform again in a qualitative way. What does that mean? In the auditory cortex, we begin to hear. So it's a qualitative transformation of the biological, of the electrochemical information into psychological information, into our perception. But at the auditory cortex, we do not understand it all. We also cannot like music. We cannot love music. There's no aesthetic experience. It's just the raw material of the sound. So what is going on? And now it's going towards real complexity of music and neurophysiology and of psychology. We construct on a psychological level what we like. So, for example, with the prefrontal cortex, with the limbic system, and at the same time, this information influences certain parts of the brain. For example, in Munich at the psychiatric hospital of the Technical University, we did experiments on singing in schizophrenia. So with patients who had hallucinations and were drug resistant. So they took the antipsychotic drugs and nothing happened. We found out that approximately 30-35% of those patients, when they sing, and important is not only just producing voice, they took singing lessons. So the goal was really artistic singing. Through artistic singing, quite loud singing, they were able step by step to control the hallucinations. So when they sang, they did not realize the hallucinations. And step by step, they learned to sing inwards, and just imagination of singing could control auditory hallucinations. Today, we are performing neuroimaging techniques. We think that in the hippocampus, there is a certain interface between music and psychosis and schizophrenia. And we know that music, the auditory pathway, can influence the hippocampus. So maybe those are the underlying mechanisms of how music influences hallucination in schizophrenia. But there is a big challenge, a big question. There is not only one music. Throughout the world, we have a lot of musical systems. For example, in India, we have the raga system. That's a microtonal system. In the Iran, we have the dastka. That's also a microtonal system. Or in Turkish cultures, we have the makam, also in Arabic lands. That's also a microtonal system. So we have in our culture, they have so it's microtonal. We know today that quite similar to language learning, we create in the brain patterns. So someone who grew up in the Iran with the dastka created those patterns like we create patterns of words, the tree, the water, and so on. And according to what we hear, there's a certain screening process. So what we hear stimulates the brain to look for those systems and to recognize melodies, or we say, that's very strange for me. And this recognition, together with life experiences, has an impact on how music works in, for example, in psychiatry. A last example, or last two examples, one very different examples, one in cardiology cardiac rehabilitation, long-term rehabilitation, and the other in obstetrics. I work especially in Austria with cardiac patients. So why do we use music? We know today through music, and it's not only the music, it is a special form of listening. They have to train a certain approach, perceptive approach towards listening. We can modulate the blood pressure and we can modulate the resting heart rates. There are still questions about the underlying mechanisms. But for example, there is a cardiological department in Germany at the Ruhr University. At this university, they combine pharmacological treatment and music therapy to treat high blood pressure, for example. There is a certain interface between the cardiac system and the music system. There are still many questions. Moreover, we know today that it's quite clear that depression, anxieties have a very negative impact on cardiac patients. So they have to deal with their psyche. We use also music therapy, music experiences to help them to deal with that. Last question, obstetrics. Today in Munich and in China, we are working with pregnant women who have anxieties and depression. It's quite clear that antidepressive and anxiolytic medication is not too good for them. So what are we doing? We also learn singing with them. Singing with a certain development of the body awareness. That has an impact on the mood. So we create a sort of self-regulation technique, music-based self-regulation technique to control the mood. Moreover, through singing and breathing techniques, they learn to better control the deep pelvic muscles. And we know that especially singing women in pregnancy have an impact on the neurodevelopment and neuroplasticity of the fetus. So it's quite a complex thing, and we cannot, it was so nice, Joachim, when you spoke about randomized controlled trials and the one dimension. We cannot, those mechanisms, so those complex mechanisms of music, breathing techniques, singing techniques in obstetrics, we cannot only isolate one thing, one dimension. It also has to do with the musical background. In Munich, we use other music than in China. Also the approach, and moreover, it helps, especially in China, where very often pregnant women feel isolated, and the most important is the child then, and which is terrible. It helps to support social inclusion. So I finish, and what I'd like to also encourage in the field of arts therapies to bring in complex thinking that combines musicology, musical, cultural approaches, and physiology, and neurosciences, and psychology, and so on. I think, especially in my field of arts-based therapies, the only future is in complexity. Thank you.
Thank you very much, Wolfgang. Isn't that fascinating to see how we have sort of three very different domains here? One, the clearly clinically critical illness-focused approach that Andrew needs for his work. Nick, from a psychology perspective, looking at the well-being over a lifespan, and Wolfgang dealing with essentially when the problems have started, can they be reversed in a meaningful way without medicalizing everything. I open the floor. We are a small group, so if you want to ask questions, we can allow you to speak. If you raise your hand, Janet will give you the microphone. I hope that's okay with everyone. Andrew has raised his hand.
I have a question for Nick and Wolfgang. So, and that is regarding the importance of the breath in both of your domains of research. There's all sorts of evidence of the importance of breathing and breathing techniques in reducing stress, the inflammatory response, and how much of that is participating in the music therapy, I wonder, Wolfgang, and Nick, how does it interact with the diagram you showed us at the end of your talk? That's my question. Thank you.
Would you like to begin? Or?
You can start.
Okay, fine. So the breath in music therapy is quite important, and today there's a certain tendency towards singing that has to do with the history of music therapy, which is sometimes a little bit naive. So sometimes it's a little bit playing on xylophones, and today we are more focusing on singing techniques, and in singing, the breathing is absolutely important, and many patients say through singing and controlling their breath, they get a form of life energy, they call that way, and they're able to control the body. For example, not in depression, breathing, and the breathing has an influence on the mood. This has deeply to do with the background. For example, breathing techniques in music therapy in Germany are very different to China. Why? Because in China, we have the qi, we have the qi energy. And it was so important, Andrew, when you focused on the energy. In China, we try to bring together Western medicine and Chinese medicine. So in Chinese medicine, not only to breathe for the oxygen, but breathing in music therapy to control and make use of the qi energy. For example, today we have a huge research project in oncology with cancer, stomach cancer, and how to use that not to get back the life energy, but to bridge the body, the dying body, and this energy, which is higher in that medical system, higher than just the physiological functions. So that has a very crucial background of Taoism and of Buddhism. So I think, and back to complexity, it is of course the breathing with the oxygen. The second perspective is the breath to control body functions, breathing that has an impact on aesthetics in singing, and breathing together with the theories of the medical system I use, whether I use Western approaches, whether I use shamanic approaches like in Siberia, or whether I use qi energy and the traditional Chinese medicine. So that's what we try to bring together.
Yeah, from my perspective, I have a little bit less data, I think. We don't have a lot of data on this. I do know that when I look at when we look at our repeated stress paradigm, where we stress people not once but repeatedly, for example, twice or 3 times, we have seen that you can alter the habituation pattern by putting some kind of intervention between the first and the second stress exposure. And we have just begun to try out different things. We can make it worse by making people ruminate about what went wrong during the stress test. We can make it a little bit better by making people activate mechanisms of self-compassion, for example, or other positive thoughts. And I think we have tried in smaller student projects that were underpowered, of course, to test controlled breathing, for example. And so this is why I'm saying it's underpowered. Students do not have a lot of time, but they have good ideas, but they only had like time to look at 15 people. And we didn't see a strong effect of breathing, but I don't think this is where the story ends. I do think that controlled breathing, maybe through the vagal anti-inflammatory pathway, could in fact have a strong effect. And now that you mentioned this, I think I will probably try to get more data on this, but I don't have any own empirical data and not enough knowledge about what might be already published.
Well, just to add to it, why do we have yoga breathing? Why do we have other breathing exercises as relaxation techniques that are well established to have a beneficial effect on your well-being? The interesting question, as Wolfgang raised and as you raised, Nick, is what are the mechanisms? That's for our students to answer. I think it might take longer than our remaining working life allows. Okay, who else has questions? Raise your hand. Trish. You are still muted.
Hi, Trish.
Now we can hear you.
Yes, I'm from Ottawa too. Yeah, I just wanted to add with the breathing, there's certainly been work on mindfulness and stress reduction, heart rate variability, and a lot of that is based on awareness of breath and reestablishing physiologic breathing. Certainly with anxiety, you tend to sort of breathe from the apices, right? And getting to the abdominal breathing certainly has an anti-stress effect and a parasympathetic, probably through the parasympathetic system. Thank you. I loved all the presentations today. Thank you so much.
Thank you.
Thanks for coming.
Oops.
Vivian. Can we unmute Vivian?
Yeah, a simple question. I enjoyed all the presentations. Fractals are repetitive, self-similar, and patterns. So with regard to music, is there this differentiation between fractal music or the need for randomness and the utility of throwing in randomness?
I don't have a lot of information on that, but I can perhaps comment, and then I'd love to hear Wolfgang's thoughts. But I think that the study of music, there is a high degree of complexity. You can measure the multi-scale self-similarity, the fractal coefficients, or there's different ways of measuring the complexity of music. And as I understand it, some of there is a high degree of complexity of certain types of music that we find therapeutic, and I think that we also know that being in nature, surrounded by fractals, whether it be waves, mountains, trees, is also therapeutic, and I think the other, I didn't mention it, but we produce entropy in two mechanisms. One is by thermodynamically, by burning oxygen to carbon dioxide and producing heat divided by temperature. So Q over T is our way we produce entropy. But the other way we produce entropy is through information loss. So there's a connection between information and thermodynamics through something called Landauer's principle. And information loss is always occurs. So if you have a classic example, if you have a photograph that slowly, degrades over time, you lose the pixels, as it were, of the photograph as the photograph ages, and you never get that back. You never get more detail, as it were. And there's always a degree of information loss in all sorts of processes, whether it be on a computer or other types. And when you think consciousness is fundamentally a process of taking an exorbitant amount of sensory information and condensing it into memories and thoughts, that is a vastly reduced amount of information. And we have the spontaneous creation of consciousness in every human being that has ever been, to our knowledge, that has ever walked the earth. That this creation of consciousness occurs during childhood or during the process of human development. And so how does that relate to your question? I think that when we take in fractal complex information, whether it's visually or auditorily, and convert that into our own internal memories, thoughts, that's a process, I think, of spontaneous entropy production, which I think is part of our healthy functioning. So that's the link, and that's why I think that fractal music, fractal visual experiences are fundamentally healthy in a way. They're restorative, as it were.
I'd like just to add some words concerning music, music in clinical contexts, and music and our mental and emotional and physical system. How to measure and how to get data. This is a very, very difficult question. I'd like to show that through an example. There are international studies how music influences the mood and how that correlates with the brain, so through functional magnetic resonance imaging. The first problem is nearly all those studies use receptive, so-called music therapy, so just perceiving, but not singing or performing. Why? That has to do with standardization. They say, okay, to abide by the rules of standardized research and of outcome measuring, I have to use one method, and that is listening would take 1, 3, 4 pieces of music. In clinical practice, we know that very often making music is more efficient than just listening, but we cannot standardize that. If we improvise, patient A improvises differently to patient D. The second is, nearly all those studies differentiate between happy music, sad music, angry music, and musicology says, oh no, that is too naive. I cannot say a piece by Claude Debussy is happy or is sad. There are many, many nuances of emotion. So we cannot reduce that. Today, it's a big question. It's really a challenge, how to bridge musicology and physiology, musicology and neuropsychology, and so on. This also was the reason to create so-called neuroaesthetics. Neuroaesthetics that try to respect the broad variety of the arts and the nuances of the arts, and on the other side, how the brain works and the brain responses, or how the brain perhaps creates our aesthetic perception. And in this context, Trish, I like so much how you spoke about the mindfulness. Mindfulness in music therapy is so very important. A small example from psychiatry in Munich, there was a patient, a female patient, age 28, major depression and high risk of suicide. And she sang, and she was supported to sing. And in one session, in one so-called therapy, she sang it. It really sounded well. And she was so astonished and said, the first time I love my music, I love my sound, and this is the moment I'm convinced of I must not kill that beauty. Mm-hmm. And that's the middle of mindfulness. Yeah. And that's so far away from 20%, 40%, 60%. And it's totally different to that.
I couldn't agree more. There is this, I coined this term of the somatopsychosocial-semiotic model of health, that there is a need to make sense out of our experiences. And to me, it's a really neglected part of medicine at large. If we don't help people to make sense out of their illnesses, whether that is a short-term illness they recuperate from, or whether it is a critical illness, or whether it's in essence a life-threatening illness for which there is no return. If we can't help people make sense out of it, we are not getting anywhere. And it was driven home to me very early in my career when a young girl dying from breast cancer said, "Doctor, I know I'm dying, but tell me why I'm feeling so healthy." She passed away a week later. So there's very clearly no relationship between what doctors describe as this is a disease and what the person with the disease, coming back to Osler's dictum, it's more important to know the person with the disease than the disease itself. That is completely lost in the way we teach and we practice medicine. The other interesting point I want to pick up on is why we don't understand how music works in its complexity. We also do not know how the social environment works in impacting our health and well-being, and why it shortens, or how it comes it shortens life expectancy in Australia in the Indigenous community by up to 20 years. But it does. We know the same thing in the very poor areas in Edinburgh and Glasgow, that people die 5 to 10 years earlier. Have they been born with different bodies to deserve that they cannot live any longer, or is there something in the environment that triggers something in the physiology that then, and that links to Nick's interest in stress research, the stress modulating pathways that lead in the end to a hyperinflammatory environment, and it's my understanding in the end that it's inflammation that kills. And aging is inflammaging. As we age, we not only increase entropy, but we also increase inflammation. And in the end, The way we are born, the way we go. We have no influence of number one. And number two is for sure. It's only a question of time. I open the question, the floor for further questions. Raise your hand, please. Or unmute yourself. I'm not sure which mechanism works here.
Yeah, Wolfgang, thank you very much for your presentation. It was very interesting. Yeah, I would like to ask you, during singing, have you data about EEG changes? What frequencies appear and what?
So it
what
happens. Does it concern singing in advanced ages, so for example in geriatrics? Is that your question?
Yeah.
Yes. Of course, physiologically, the voice goes down. So also when you study singing and you work at opera, for example, a soprano, after the age of 55 will not sing anymore in opera. That's a physiological rule. On the other hand, I think, and that's a very important point, in music therapy, we have a certain self-identity with the voice. So it's clear at the age of 70, 75, the voice is different from the voice we had when we were 25. But there is an identity. I think, and we have a lot of experiences with that in neurogeriatrics and so on, that people must be aware and get aware of the importance of one's voice. One example which was fascinating for me, really fascinating. 8 years ago, we had research on singing in patients with dementia in Munich. And there was one man, and according to his diagnosis, he already has lost language abilities, no communication. And the nurses said, perhaps he can listen, perhaps he will somehow enjoy that group singing activities, but he will not show that he's happy. There will not be any interaction. Okay, we began. After approximately, so the setting was with students from the conservatory in Munich, 4 or 5 students singing with the patients. And once he began to look to those students, and we had somehow the impression there's a certain awareness of what is going on and a certain first step of communication. And that was really funny. He had his stick and he began to rhythmically to make the beat, to play the beat. And that was very important. Approximately after 2 months, he began to move his lips, and we recognized he tries to remember the texts. And he began a little bit to sing. So it was not really the melody, but we could feel his singing. And after 4 months, and that was really shocking for the nurses, who knew that's a man who has lost his language. He looked at one student of me and said, "You are singing so beautifully, you should sing on TV." And that was incredible. That was, and I think that has to do with the fact that this man has refound his voice and his vocal selves, and on that basis, he managed somehow a form of recovery. Of course, the dementia, the Alzheimer disorder went on. Of course, we cannot stop that. But what we found out after, and that was important, and that also has to do with mindfulness, we found out that for 1.5 to 2 hours after singing, also other patients could communicate. After that, they fell again into that night of consciousness. But we could inform the family members and said, listen, Thursday, 3 o'clock, we have singing. That is over at 4 o'clock. If you come at 4 o'clock, it may be that you can talk to your grandfather. And that was totally different. Before that, they came and grandfather's doing nothing. And now they could talk to him. And that was a tremendous change of quality of interaction. So that is joking also what you are saying, that has so closely to do with philosophy of life, with what are we, what's the bridge between medicine, neurology, geriatrics, and the quality of life and the essence of being.
Yep, couldn't agree more. I think, Ben, you had your hand up. No? Okay. I guess I know that Andrew has to leave us in a moment. What I would like to ask the three of you, how do you think your understanding of the complexities of physiology impacts on the way you practice in your respective disciplines? And in particular, I think Wolfgang has made it very lively how it affects how he works. But I'm really interested, Andrew, how it impacts on your work, being in sort of that very other end of the spectrum of medical care.
Yeah, it has an enormous impact, I would say. I would say that complexity is at the root of the way I practice and the way I do science. First of all, I teach a kind of a holistic approach to critical care. We often reduce our critical care patients to a problem list in our intensive care unit, and that's the way we discuss patients. And I always highlight the need to have a complete summary of all of the issues of a patient in a holistic fashion prior to addressing, what the plan is, and not approaching it in a reductionist, problem A, solution A, problem B, solution B, and it And we often, I'm at a conference, and that's why I have to leave. I'm going to actually give another presentation in about 15 minutes. So, but there's all sorts of talks on music therapy in the ICU about, engaging the family, how to pursue a holistic approach to critical care. It's just things are really wonderfully progressing. But also this is a trials network, so people believe in the fundamental science of clinical trials. The other thing I would say that is sort of in complexity inspired is the appreciation of the inherent irreducibility of uncertainty. So the reality that you have to continuously, dynamically, iteratively make sense of an evolving dynamics situation is also part of being a good physician. So I think a holistic approach, uncertainty, and then for my science is all about understanding the rhythms of the body and measuring those, and then turning those into clinically intelligible, predictive models that we then can embed into clinical decision support tools. So I would say that's the top 3 ways that I embed complexity into my clinical work. But Yeah.
Thank you. Nick?
Sure. Well, the only thing I practice is research, of course. So it's a little different perspective, but for me, complexity is something that I strive to understand complexity. So what we're doing, what I presented was, I think, like a very one-dimensional view. I was just talking about, how does cortisol respond? How does the sympathetic nervous system respond? How does the inflammatory system respond? But in reality, I'm interested in response patterns. And I mean patterns not only as temporal patterns from first to second to third exposure, but also about like trying to integrate the interactions between the different systems. What does it mean if one system responds strongly at first and then slower and then lower the second and third time? Does it maybe reactivate at some point? This is incredibly difficult to study. And I don't know if I have enough work time left to kind of get closer to the solution, to a solution. But what I'm trying to work on is really to not just look at this one dimensional view, cortisol, and that's it, but to integrate all of that. And I do know that I cannot do it with my statistical tools that I learned as a psychology student. I'm therefore also working with people who do AI and machine learning, and I hope that they can help me or work with me. That's something that's in research area I'm doing right now. But generating enough data to actually make these tools work is something that's hard work. We're working on it, but it'll take a bit. But that's my view on complexity and how I integrate it in my little field.
Thank you. Can I pose a provocative question in a way? Are we doing research the wrong way around? We are interested in one thing and look how it, whether it works or not. From my perspective, from complexity sciences, complexity always leads to patterned outcomes, which are not random and which are not infinite. So if you look at a simple condition like diabetes or ischemic heart disease, we know that there are particular patterns in how patients go through the rest of their life with these conditions. But when someone presents for the very first time, we really don't know, does this person behave like pattern A, pattern B, pattern C, and so on. But if we would study the outcomes of patterns and ask the question, what are the contributing factors, and that comes back to a bit of what Andrew said about predictability in patterns. Can we identify particular patterns or features that make that pattern, and then start at the beginning of seeing a patient and say, let's see what kind of features do you have, to then be guided in a way of saying you are more likely to, whatever you do, you will do fine, or even if you do everything right, you will still be in a big predicament. So from a very pragmatic point of view, being a GP and being confronted with lots of patients with common diseases and knowing that they all behave slightly differently. Now, at the end of my medical career, I can say when the patient walks in and tells me he has diabetes, it's going this way, that way, or the other. So you get a sense of being able to interpret the complexities or see the complexities behind it. But should we be studying this in a much more formal way to help young colleagues to be, or students to become effective much earlier in their career? What are your thoughts, audience?
Yeah. Can I add something here? Can I add something?
Go ahead.
Yeah.
Yep.
Yeah, I'd like to add to that as crucially important. As a practicing physician and cardiologist, we see pattern recognition all the time, but there's tremendous variability and exceptions. So we have to balance both. At the same time, we look at evidence-based medicine as seeking those patterns and applying to individual diverse patients. So I see chaos and complexity thinking as a transition factor from the evidence-based medicine, which is necessary to translate and transfer out into the individual patient. That's one. Two, now to come back to what Dr. Stromberg just said, how do you get this to people who are practicing or learning medicine? And therefore, I would suggest, and we've been working at this for many years, instead of applying chaos and complexity specifically to specific situations like Dr. Seeley does and many people admirably do, we propose that there should be a complexity thinking in very simple terms, embedded in medical school and elsewhere as essential learning and thinking, and then the students will apply this. And it will then extend beyond medicine to global crises like climate change and all the other global crises we face. So you can start at medical school and using a simple complexity thinking proposal in general.
Okay, any other questions? Wolfgang, you are muted.
It's not really a question, it's somehow a response or a contribution to your question about the patterns. I think traditionally medicine in the West ignored two important questions, two important issues. The first is the relativity of patterns. For example, if I study mitochondria, patterns are quite stable. On the other hand, we always find in psychiatry that patients who have to fill out an inventory say those items do not really mirror my experience of depression. So there are issues, medical issues, with very clear and very stable patterns. The second is we have issues with a high variety. And there's always the problem, and Vivian, it was so great when you said it's full in cardiology, it's full of exceptions and of variations. And very often medicine thinks a variation is, sciences, medical sciences think variation is bad. So we should reduce variation. If I have the interval of confidence is very clear, then it's the best. We have to think over the nature of what makes this pattern. The second perspective is the pattern in a bigger context. So I can take out a pathological pattern and I have to understand it in a bigger context. And as soon as I see this context, it's not stable anymore. It is dynamic and it's very complex. And I think those two issues are broadly ignored and also leads to a flood of misinterpretations of studies. Once I remember some years ago, I had with one of the leading people in the board of the Lancet. And I discussed with him those problems. And he said, you're right. But if we criticize evidence-based medicine, I will lose 80% of the articles of the Lancet. And so I think a problem is a certain ideology which is established and which prohibits, which really obstructs processes in complex thinking.
I couldn't agree more. I want to finish off with this slide. On the left-hand side, you see a conceptualization of how to see the layered and hierarchically layered structure of our well-being. It is essentially scale-free, from public policy to genome function. And one of the things I think that we have discussed today in broad terms is how do these interaction between the external lead to the internal, and the HPA access mechanisms affect all of our function. There's certainly now very clear evidence that they impact on the neuronal function in the brain. There was just an article today that says that the brain has its own immune system, separate from the general immune system, to regulate brain function, and in that sense then the effects of brain function as mental well-being. At the same time, I have put up advertising for our own forthcoming conference in November in Phoenix. I hope that you feel inspired to come along and have further exchanges about this particular topic domain, as well as any other. With that said, I thank Wolfgang and Nick for their contributions to make this a reality. Andrew already had to leave with a good explanation to promote the course a bit further. For those who have a start of the day, have a good day. For those that are close to going home, have a good afternoon. I can't see anyone from Australia here, so I have a beer now, and have a good night. Thank you very much for your participation, and I hope you join us in due course for our next seminar. Thanks a lot.
Thank you.
Thank you a lot.
Good night.
Excellent.